Hi everyone, Dr. Traci Moreno, psychologist, and today in our therapist and training series, we're going to talk about suicide risk assessments. We are going to go through and talk about like some examples of things and how to talk to clients about suicide, and so this could be a triggering topic for people, so please use caution in listening to this recording. Most people shy away from even talking about things like this openly, but I think it's too important of a topic to shy away from, and I think it actually needs to be talked about more. So, but if this is something that could potentially trigger you, you can, certainly just stop this recording and come back whenever you're ready. Okay, so let's talk about the main elements of a suicide risk assessment. Depending on the agency you work with, some people could refer to it as a suicide risk evaluation or risk assessment, whatever it is. An SRA, SRE, we use lots of acronyms in our field. So let's go through the three main items for it. You have ideation, intent, and plan. And we're going to break those down and go through those separately. So let's first talk about the ideation. So this is the, having the suicidal thoughts. And this can look very, very differently for each person. So there's two main types of suicidal ideations. There's passive and active. Passive thoughts are those thoughts that are more passive in nature, meaning that they're not thinking of wanting to hurt or kill themselves, but they wish they would, like it would happen like naturally or by accident somehow. So the most common thoughts for passive thoughts would be, I just wish I would go to sleep and never wake up. I wish that, I just wasn't here anymore. I wish God would take me, or like something, a car accident or something like that, where, it was, they're not taking an active role in doing it themselves. It just kind of happens to them. Now, just because these are passive thoughts, it does lessen the level of risk a little bit, but we still have to take this very seriously because, it still can, things can escalate very quickly. And so we want to make sure we assess it appropriately, even with passive ideation. So let's talk about active ideation. Active ideation definitely makes the risk level higher. And active ideation is that they actively are thinking of wanting to hurt or kill themselves. So then once that is assessed, we want to talk about their intent, which is, what is their intention of actually doing it? Do they really want to? Do they, or is this just a thought? And, there is a big difference between thoughts and, adding the behavior behind it. And so a thought can be just a thought, but again, we have to take this seriously, and we have to still do our due diligence to weed this out to determine their appropriate risk. And then what precautions we need to take from there to, protect the client. So with intention, we want to, assess, are they really wanting to kill themselves? Or again, is this just the thoughts? And I really try to normalize the thoughts in a sense of, one thing we have to remember is this ideation is unfortunately a common symptom of depression. And, so it's sometimes depending on their history, it can be normal to have the thought. But the thought doesn't actually mean that they're going to put that into action and do it. So that's what we're assessing out with the intention. One of the biggest saviors for me is one very simple statement. And once we start to talk with them about their ideation, kind of like, what can you tell me? Can you give me an example of some of the thoughts that go through your mind, and what are the triggers to these thoughts? where does this come from? Why do you want to kill yourself? Why don't you want to be here anymore? What's happening, right? So as they're explaining their experience with this, and then we're going into intent. And again, this would be, of course, if this is what you're getting from what they're explaining, the number one best statement to kind of give them is, it sounds to me like maybe you don't actually want to die, but you just want the pain to stop. And every time I have used that statement with a client, you kind of see, the wheels turning, the light bulb goes on, and every single time they're like, you're right, I just want the pain to stop. And so that alone means that there's hope, right? Because hopelessness is one of the number one risk factors to suicide. And we're going to go through other risk factors as well in a bit. But if we can get a little bit of hope in there, there's hope, right? So we want to kind of, and from there we can roll into, look, you've been feeling this way for, it could be a year, it could be 10 years, it could be most of their life. Can you commit to yourself and me right now to give us working together for 3 months, let's say, and let's see what happens, because you've already been feeling this way for so long. What's another 3 months? Can you commit to me to take kind of suicide off the table as it not being an option? The thoughts you can't help at times, you can have the thoughts, but committing to not take it any further than, just allowing it be a thought and that's it, for 3 months. And that commitment also makes them future oriented, right? Which is also a protective factor that, again, you also want to document. So this can be, that intent is really important. It's some things that you want to find out in terms of their history. Some things that can make them at higher risk is, have they ever attempted suicide before? And when? You want to get a timeline. So if they've attempted suicide within the last year, that makes them a higher risk. If they have more than one suicide attempt throughout their life, that makes them at higher risk. If they have lost anybody close to them to suicide, or maybe they even know of somebody, it doesn't have to be close to them, but maybe they even know of somebody, it could even be like a celebrity or something, but someone who has some sort of personal, they feel a connection to this person, that can make them at higher risk. So get that timeline, and you want to try to differentiate between an actual suicide attempt and a potential cry for help, right? That's very important too, because that's assessing their intention. Because if it was really a cry for help, their intention was not necessarily to die. It was to get help, to get somebody's attention. It's like somebody is crying out, like, please help me. And we don't want to bring this to their attention, because we also don't want to minimize that differentiation is for us only. We never want to minimize like in their minds an attempt and say, oh, well, that doesn't sound like an attempt. It sounds like a cry for help. Unless you want to use that as a protective factor, and also building upon the statement of, it sounds like you don't want to die. It sounds like you just want the pain to stop, right? And then you would do it in, a very careful and sincere way to say, well, do you think maybe the previous attempts, it kind of sounds like the way it played itself out, it could have been a cry for help. That's always a good way to challenge clients to think about things a little bit more, is to pose it as like a potential theory or a question to them that they have to answer, rather than us making that statement or evaluation to them, which could sound judgmental and minimize their experience, which we absolutely never ever want to do. Okay, so let's see. The third item to evaluate is plan. So if they have ideation, is a yes. They have the intention, it's a yes. Now we go to plan. Plan is, do they actually have a plan? Have these thoughts and the intention gone so far that they've come up with a plan of how they would want to hurt or kill themselves? And of course, having a plan, and the more detailed the plan is or elaborate the plan is, that puts them at a higher risk. So, and then if they do have a plan, you want to find out what that plan is, and of course, find out how detailed that plan is. If it's something a little bit more vague, or they say, I'm not sure, they're still at risk because they still have the ideation intent, right? But we want to find out, is that plan also there? Anyway, so the plan could be, probably the most common thing is maybe medication or some sort of overdose on prescription medication, over-the-counter medication, or something with drugs or alcohol, or a combination of such. So then we want to find out if the person has the means to carry out this plan. So this is kind of a fourth area to evaluate, but it's part of plan. So if plan yes, then you go to means. So you want to find out, do they have the means available to them? Do they have, if they're saying they want to, overdose on prescription medication, do they have that medication available? Are they saving it up? Where are they getting it? Is it maybe from, another household member of the household that they're getting the medication from? You want to find all of this out. Same thing, it could be, they want to shoot themselves. Do they have access to a gun? Do they own a gun? Something like that. And then what we want to do later on, and we'll talk about this later in a protective factor, is we want to make sure in moving forward that we kind of limit or take those means away from them, right? So if it were a gun, we would get them to give the gun to, lock it up and give it to somebody, a loved one, somebody they trust, to put that gun away while they're at risk. Or if it's a gun of a family member, to tell that family member that they've got to get that gun out of the house. For prescriptions, if it's their prescription, it's like they have to give the prescription to a loved one, or somebody else in the house. That could only give them a little bit at a time to be able to moderate that for them. Or if it's somebody else's prescription, they've got to put that away. They've got to hide it better. They've got to do something with that. So we have to take all of those necessary precautions. I want to go back to when I was saying to differentiate between a true suicide attempt and a cry for help. Let's talk a little bit about how you differentiate that. You want to find out, what did they do? I'll give you some examples, and again, this can be, we're going to go through examples and graphics, so this could be triggering. Just keep that in mind. If you need to stop at any time, go ahead and stop the recording. But let's say, one of the most common things is people say, well, I tried to cut myself with, a knife, a razor blade, something like that. When I hear tried, that's always that red flag. So what do you mean tried? Did you actually do it? Or did you have it in hand thinking about it? Like, take me through your experience, right? And again, you want to make sure when you're questioning this, you are being sincere and curious, and not judgmental. So obviously, if they actually cut themselves, that puts them at higher risk. If they held it and didn't, that could potentially be a cry for help. Also, you want to find out the timeline of, what time of day, when did you do this? Where did you do this? Was anybody home at the time after you did it? Did you have any, regrets or remorse right away? Did you call anybody? Did you tell anybody after or before? If they told somebody, or somebody, a lot of times I've found that the timing of, if they live with somebody, they did it like maybe right before the person was set to come home, that could potentially be a cry for help. So different things like that. If they called somebody right after and told somebody what they did, that could be a cry for help. If they again tried to do it but didn't actually do it, that could be a cry for help. So that's how you can differentiate that. Okay, so let's talk about, we're going to go through some questions to assess these elements. If you can already tell, my way, and of course this is my way, and there are many, many ways. And if you work for an agency, they're going to have a standard, SRA that you are going to complete, discuss with your supervisor. They're going to have a whole procedure for this that you are going to need to follow. And if you're just in training, if you're at a practicum or internship, and this is all new to you, I would say definitely use a standard suicide risk assessment. And there's a ton out there. There's a lot online. Just make sure it's something that has good validity and reliability, that it's, it's just well evidence-based, right? So, but the goal for me is, instead of going through, you have your evaluation, your assessment in front of you, and you're just you're just kind of like, it's a checkbox, and that lacks personalization to me. And I feel like we don't end up getting that true essence of their experience to be able to assess it appropriately. It's kind of cold to me, which isn't what we do, right? So when I am training people who are licensed eligible at this point, so they've already gone through practicum, they've gone through their internship, right? So they have a little bit more experience with this. I personally don't want them to use a standardized template. We need to have all of these elements and questions and level of risks memorized in our mind, right? So that we can just talk and have a conversation with the client where it's organic and it's natural, right? Because you don't want to be with with your clipboard kind of going, okay, when was the last time you attempted suicide? How many times have you attempted suicide? Is there anybody that has ever attempted or completed suicide? Check, 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 right? And then you're just kind of like adding numbers. That's very impersonal. And, think about if that were you on the other side of that clipboard, you probably wouldn't feel safe to really open up. And that means we're not going to get a true, accurate assessment. And that could end up being either where the client is potentially faking good or faking bad, right? Meaning they're either going to exaggerate or feign for whatever reason, some sort of secondary gain or whatever, to make their risk worse. This happened all the time. Again, if you're not aware, I worked in a maximum security prison. So that was a very common thing. You end up getting these kind of special privileges for if and kind of separated from the general population, if you are found at greater risk, put into kind of the hospital section with better food and, I worked at a men's prison, so of course they wanted to see, the females and, things like that. So, there's all kinds of reasons why people will kind of worsen and fake their symptoms. And that's easy for them to fake if they're just saying yes, no, down a thing, as opposed to really having a conversation with them and really understanding their experience. That is a lot harder to be able to fake, and you would be able to pick out any inconsistencies or anything that wasn't congruent with our assessment. So also, or on the other hand, they could be kind of minimizing their symptoms as well. because now all of a sudden this is like a formal, like, and they could be, you know, a lot of people are scared to, oh, I'm going to be taken to the hospital, you know, I'm going to, you know, because now our limits of confidentiality kick in. And so they could kind of shut down at that point, which again, this all defeats the purpose of even doing doing the suicide risk assessment. We want it to be organic as possible. Okay. So as you do these, as you gain your experience, just memorize this stuff, just have it, and try your best to do it more as a conversation with them. Okay, so some of the questions you can ask is, can you talk to me about the thoughts that you're having, right? Or can you give me some examples of what are some of the thoughts in your mind? You want to try to have open-ended questions that get them talking. Where are the emotions that are there emotions connected to these thoughts? Like, what emotions come up when you start thinking about this, right? And in the back of your mind now, once you're going through this, I also start, you know, I'm already treatment planning in the back of my mind as they're talking about this, because once we move forward, you know, even if they, you know, even if they do go to a hospital for further evaluation, or they get put on a suicide risk hold, like a 72-hour hold or something like that, they're gonna most likely be discharged, and you'll start seeing them again. And you want to be able to pick up where you left off and not have to re-go through this, because this could be pretty traumatizing for them as well. So you want to be, you know, because the emotions, you know, what was triggering these thoughts, what was the recent trigger that brought these thoughts about, you know, that's all really important. So you also want to make those notes for yourself. You want to find out how often do they have these thoughts? How intrusive are they? That is really important too, because, you know, again, thoughts can be merely just thoughts without that action behind them. And, you know, that could be something else that during treatment you can emphasize with them, to not be so scared of the thoughts. Because again, we want, and even I'm going to jump back to ideation. We want in the beginning, we want to kind of normalize and go, you know what, I get, you know, with somebody with depression or the, you know, trauma, the things that you're going through, it can be common to have suicidal thoughts. So I want you to feel safe in, you know, talking about them openly with me. However, I do need to remind you of my limits of confidentiality, and then you'll remind them of that. But you also want to like encourage them that I just want you to know that you sharing with me the thoughts doesn't mean that I have to break that confidentiality. You know, there's more to it. Like, I have to believe that you're going to leave my office right now and attempt, you know, suicide for me to break that confidentiality. So, because you want them to be able to still have this safe place to discuss this stuff. If they're not allowed to discuss it, what are we here for? Right? I mean, it just makes no sense. So I think that's always worked for me. It's a great way to kind of keep them talking and not like scare them and shut down, and, you know, out of fear of being like, you know, hospitalized immediately. Okay, so some more questions. Are you scared you might actually listen to the thoughts and like put behavior to them and try to attempt something? You know, again, have you ever attempted in the past? What stops you from doing it? This is a huge protective factor. What stops you? What has stopped you in the past from attempting or taking the thoughts further? This is what you can really build upon in the treatment as a protective factor. The most common things people can say is maybe their family, their kids, parents, or religious or spiritual reasons. So that's good to make note of it. Have you ever thought of how you would do it? You know, that's going back to the plan. And then do you have what you would need to do it? That's assessing the means. So let's talk about the top risk factors. So again, like I mentioned earlier, one of the biggest risk factors was the number one risk factor is hopelessness, right? That's why through this, even through this assessment, we can try to instill some hope. For an example, like the statement I had given you earlier. So hopelessness is the number one risk factor. Previous attempts, again, differentiate attempts from cries from help. And within 1 year, if they've attempted, that puts them at a higher risk. Knowing of someone who has attempted or completing suicide, any substance abuse, would put them at higher risk. Any mental health disorder with maybe impulsivity or a mood lability puts them at higher risk, and a poor support system puts them at a higher risk. Okay, so to go through those just really quickly, if you're making notes: hopelessness, previous attempts, especially within 1 year, knowing of someone, you don't have to personally know them, but knowing of someone who has attempted or completed, substance abuse and mental health disorders, specifically with mood lability and impulsivity, and a poor support system. Okay, so that is the essence of a suicide risk assessment. Please comment or ask any questions. We are also going to go through the next steps of what do we do then if they're determined to be high risk, moderate risk, or low risk. All right, thank you so much.